Hi, welcome everyone. Today is the 15th of October 2020, and we kick off with a series in regards to breast cancer care and cure. This is one of MHM Clinical Roundtable, where we have the masters and we are going to have expert knowledge, really sharing information. My name is Michaeline Holder-March. I'm the founder of MHM Health Consultancy, MHM Leadership Lab, MHM Virtual Assistants, and MHM Business Solutions. And I am a nurse, midwife background, and I've been a health executive for a long time. And it's really paramount that we share information. It's such a great privilege today to have breast care, breast experts, breast surgeons, breast scientists here so that we could actually share information and actually explore practices. So we welcome on board all our great panelists. Hi, welcome on board. Welcome on board. First, I'd like to welcome Dr. Rami Tabaka. Could you introduce yourself? I think it's so great to have you here today. Tell us a little bit about you.
Good evening, Marceline. Thank you for inviting me. I'm a general surgeon by training. I've been practicing in the United Kingdom for the last 21 years. For the last 10 years, more specifically in breast and oncoplastic surgery. Thank you for inviting me, and it's an honor for me to be with you today to talk about this cancer. And I hope everyone is okay at this difficult time in the world. Good evening.
Okay, it's such a pleasure to have you here, and we look forward to hearing so much about what you've been doing. So it's just great. I'd like to introduce Dr. Figueroa.
Hi, nice to be here. Thank you so much for the invitation. My PhD is in molecular genetics and microbiology, and I'm an epidemiologist, and I've been studying breast cancer in Europe, the US, and also in Africa. So having conducted some studies with Beatrice Wayafi in Ghana, but also working in Kenya and quite interested in understanding breast cancer health disparities.
Wow, that is really impressive. And you know, we did a conference recently, and we realized that breast cancer affects Black women quite differently. So, and the genetics behind that. So we're super excited to hear all that you are going to tell us today. And then we like to introduce Dr. Malcolm Samuel. So can you tell us a little bit about yourself, please?
Hi, good evening. Michaeline, thanks for having me here. I'm a general surgeon by training with specialty interest in renal transplantation and breast disease. I run a breast clinic at the Trinidad and Tobago Cancer Society where we do screening mainly. And most of my private practice is in breast surgery. And yes, to agree with what you said, breast cancer in Black women is a totally different disease than in Caucasians. It's been eye-opening, some of the things that I have seen here over the last 14 years.
Yes, and this sort of platform is ideal because it gives an opportunity for shared practice, gives an opportunity for everyone to actually, you know, find out what the other has been doing, and actually the new advancement in technology now, and also the recovery rate and all of that. So it's really important. At this point, we like to introduce our lead panelist, who is well known. I remember meeting her at the economics had a massive conference about breast cancer, and they brought her up on the podium, and they just talked about her brilliance and her pioneering work that she's doing with the Peace and Love Hospital, the medical tourism. And it's such an honor to have you here, Dr. Beatrice. Can you introduce yourself?
Yes. Unfortunately, I have a very bad connection today, but I'm a breast surgeon the president of Breast Care International, the chief executive officer of the Peace and Love Hospitals. Yes, I'm happy we work together with Dr. Johnny on the Ghana Breast Health Study, and a lot of things have been done in the area of breast cancer prevention and measures that we can take in our part of the world. So to talk about the types of breast cancer, I'm not sure if I will be able to do the presentation because the internet is just unstable today. But I'm happy to be of this great initiative.
Okay, well, don't worry. I'm sure Dr. Rami will, or Dr. Figueroa will actually take over and be a lead for you and ensure that you are still participating. And I think the world that is looking on here, we are all so many healthcare professionals around the world. We know what it is to have tech issues. So please don't worry about it. We're glad that you're here, and I'm sure you'll be able to chip in. So we are going to start. But let's just start off with this concept. Breast cancer. Because breast cancer is affecting the male. We know that now. It was like a hidden secret, but it is. So when we're talking about breast cancer, we're talking, it's gender friendly. That's the best way to put it. It is gender friendly, but in men, it's hardly spoken about. I think it has to do with the fact that, all the cosmetic aspect of it. So if we could start off by Dr. Beatrice, can you tell us for students and medical students that are out there, to define breast cancer for us, please?
Yes. So thank you for having me again. And I must say that breast cancer is not one disease anymore. And when we mention breast cancer, we need to understand that there are different types of breast cancer. I'll start by touching on the ductal carcinoma in situ, the DCIS. We wish all our cases were DCIS, but unfortunately that is found normally at the very early stage. Can you show my slides for those who are with us to watch?
Of course. Let me get your screen up.
So on my slide, you'll find the normal cell. And so when we are talking about the DCIS, we're talking about the non-invasive or the pre-invasive breast cancer. The milk ducts are normally affected. The surrounding tissues are spared. And so let us look at the first slide. And so DCIS can become invasive breast cancer. And when it's left unattended to, it can even spread what we call metastasis. So when it's inside the duct and has not gone out of the duct, that's when we say it's the non-invasive ductal carcinoma in situ. Then we move to the invasive ductal carcinoma. It's also known as the infiltrating ductal carcinoma. And it's cancer in the milk duct that has spread to the fibrous or fatty tissue of the breast out of the duct. The most common.
Okay, so I think one of the key things here is that it was an explanation by Dr. Ade Waife about really.
So the most common form of breast cancer is the invasive ductal carcinoma. about 80%.
Okay, so I will go through Dr. Wife's slide. Dr. Figueroa or Dr. Rami, would you be able to pick up on these slides here for Dr. Wife as I go through it here?
Yeah, sure. I mean, while you're doing this, just to mention here how common is the breast cancer is. So breast cancer is a common disease, especially in the northern part of the of Earth. It's 1 in 8 lifetime average speaking. If you go to street and pick up, so 1 in 8 will have breast cancer in their life. That's what we're expecting that women to live for 80 years old on average time in the United States or in the United Kingdom. So each year, for instance, in the United States, there's about just over 260,000 women diagnosed with breast cancer. In the United Kingdom, there's over just 52,000 breast cancer diagnosed in women. So it's a common disease. And you mentioned, Makalina, the male breast cancer. Male breast cancer, on the other end, is quite rare in terms of the occurrence. And it's about 1% of breast cancer happens between the two genders. So I can see the slide here, inflammatory carcinoma. So inflammatory carcinoma is one of the rare cancers. It's about 2 to 5%. And just quickly, I think we have one of our colleagues who was talking about the stages. So again, stages of breast cancer, there are different classification types of stages. There's a TNM, T for Tango, N for November, M for Mother. This classification meant to classify how progressed or advanced the disease is, and it's been overseen by the Association of Surgery in the United States. However, broadly speaking, we can talk about 4 stages, stage or 5. Stage 0, where there is a cancer, as Dr. Beatrice mentioned, is not yet left the lumen of the lobular units, which is the functional units, ductal lobular unit in the breast. And then stage 1, when the cancer starts to become invasive and leave the membrane, the base membrane of the duct into the surrounding tissues, and then become, by definition, the name of invasive. And then depends on the size of the cancer and whether it's gone to the regional lymph nodes, then the cancer can be classified on these 4 stages. So stage 1, again, there are different categories in it. However, stage 1 is less than 2 centimeters, broadly speaking, and not moved into the lymph nodes. Stage 2, it has gone to the lymph nodes, or it's got bigger, between 2 to 5 centimeters. Then stage 3, and this is where the inflammatory cancer comes in. So stage 3, where it's bigger than 5 centimeters, or the lymph nodes, more than 3 lymph nodes being affected, or the cancer has gone to the skin itself, specifically the dermis, or ulcerated, or it's gone to the chest wall. So that's the stage 3. And then stage 4, when the cancer moves distantly into the rest of the body organs, including commonly brain, lung, and bone.
Yes, and thank you for that. There is so many interest in actually identifying clearly when it is the second stage, when it's the third stage, and when and sometimes men and women don't realize they have breast cancer at the first stage, and so therefore it is really critical for people to for us to be able to define that, because it helps for health professionals and for us to be a little bit more discerning in what we hear our patients are saying. And I know for a fact someone who really shocked me. They were actually had some food on their chest and they were about to move it, and there they felt a lump, and they would have never known they had breast cancer at all. It was just by and thankfully they are in good health now and good speed, but it's really critical. I mean, Dr. Figueroa, do you have anything to say about the stages of breast cancer and the spread of it?
No, I mean, I think definitely one thing we know in low and middle income countries such as Ghana, where we've done some work, is that obviously women come in with much more advanced stages compared to other places. And another issue, of course, is screening. Mammography screening is much more prevalent in places like the US and the UK. And that has also changed the type of breast cancers that we detect in screened countries. So again, this is another factor that we need to consider when we're looking at different types of cancers. So much lower stage here in the UK or the US or Australia and other places in Europe.
Dr. Samuel, is there anything you'd like to contribute on this topic, the spread and the stages?
Not really. I mean, Dr. Rami has done the staging quite well. I mean, our experience here is that we tend to have patients who present more advanced. And because of deficiencies in our services here, in terms of having a biopsy, proper surgery, mammography is not a problem. We do have a number of units, both in the public and the private sector. I work at the Trinidad Cancer Society, so we have a new digital mammography, and we offer screening for breast cancer as well as cervical and prostate. So mammography screening is quite accessible. It's what happens after the diagnosis is made. We do ultrasound guided biopsies, but the pickup or the service in the public hospitals is not what it should be. It's not what it should be, comparing it to where I trained in the UK and where Dr. Rami practices. It's inadequate. There's no coordination. There is a central unit, a central oncology unit, which does gynae and breast surgery, chemo, and has recently opened a linear accelerator machine. So we have fairly up-to-date radiotherapy. However, the unit is short-staffed and it's overburdened. So that unit alone can't handle the number of positives you see in Trinidad. And then we also act as a
population.
Well, yeah, I mean, our population in Trinidad is about 1.4 million, but you see some of the smaller islands have no radiation, for example. The oncology services are, I don't want to be I don't want to be controversial, but the oncology services are mediocre.
Okay, like many third world countries and countries that are in development, and some countries that are also developed, I have seen that in regards to breast cancer, late diagnosis is one of the key things that end up having poor outcomes. There's no doubt about that. And there's lots of work to be done in regards to not only breast cancer, but prostate and cervical cancer. And so at this point, I think it'll be really good to get Dr. Figueroa to talk. Let's talk about genetics, because there's been there's been different research in regards to genetics and the influence and the impact and whether it's linked. There's a direct causal link. And so therefore we look forward to you presenting, and we look forward to hearing from you.
So I don't have any slides specifically on genetics, but I can discuss it and just give you guys an update on where things are at. So in my work, I've been involved in various different consortium activities that are looking at defining both the common and rare genetic mutations that actually are associated with cancer. And these are studies that have cumulative number of cases closing in on 500,000 breast cancers. One of the issues, though, is that it's been mostly of European ancestry and very little diversity. And we know that this is a big issue. So most of what we know about breast cancer genetics comes from European ancestry populations. And we have, obviously, many people have probably heard of BRCA1 and BRCA2, which are very common. Very rare. We have some common variants that actually are also associated with risk. And we've been defining, as part of the Breast Cancer Consortium, led by Doug Easton and my colleague Monse Garcia Colosas at the National Cancer Institute, defining what are the other common and genetic variants that actually are associated with risk. And we're getting close to understanding, at least in European populations, about 50% of the risk that's related to genetics. And the hope is that we can define people who might be more susceptible to breast cancer so that we can hopefully prevent it ever occurring. This has been a bigger challenge in African and other diverse populations because we just don't have as many studies out there, and actually very, very few. Ghana, that I've done with Dr. Beatrice Wayafi, is one of the few studies that actually has data from Africans. And so we are trying to overcome this limitation. And I think the other issue is we know that women of African ancestry tend to have breast cancers that are earlier onset, and we don't understand why that is. This is likely going to be genetics, but also environmental factors. I can talk a little bit about that as well.
Yeah, environmental factors, I think, plays a significant role, especially in parts of Africa where there is the mines as well, and a lot of pollution, environmental pollution, which is quite visible. So it'd be very interesting to hear from you in that context.
So maybe I can give a little bit of my presentation.
Yes.
Application window, PowerPoint, hopefully should come up. Oh, sorry.
Cheers.
It's lost permission.
You can email it to me as well.
Yes, I'll just talk about it, I guess.
Okay.
So basically, we have seen, that some of the key factors that are associated with breast cancer are reproductive factors. So having children earlier in life, having more children tends to protect for breast cancer overall. And of course, this is mostly in European populations where we see that there's an inverse relationship with the number of children that you have and the earlier you have them. What we've come to learn from our studies, both in European and now also in Africa with the Ghana study that we've done, we see that there's actually, this is consistent in multiple populations. The thing that has now emerged is that it's important to also look at the type of breast cancer that you have. And estrogen receptor is one of the key markers that distinguishes at least two types. Now, we know there's probably more than that, but at the very simplest level, we can look at these things by estrogen receptor status, where we have either estrogen receptor positive or negative breast cancers. And what's interesting is that now we actually know that breast cancer and having children on parity seems to increase the risk for estrogen receptor negative breast cancers while protecting for ER positive breast cancer. And this is becoming quite consistent across multiple populations, both of European as well as African ancestry, including a cohort study that was conducted in the United States called the Black Women's Cohort Study by Julie Palmer and colleagues. So this is an important factor we also just recently published, and I'm happy to share the slides afterwards too, with the Ghana Breast Health Study, which we carefully collected biopsy tissue at the time of diagnosis. 3 hospitals in Ghana, in Kolebu, Konfonochi, and Peace and Love Hospital. And we were able to see that actually in Ghana, many women, we see a very strong protective effect for both number of children and breastfeeding. Breastfeeding is so much better in Ghana.
Yeah, that's
so much better. And it's probably one of the reasons why we see the rates so low. So even though obviously, we know there's huge differences in the rates of breast cancer per population. And so even in Ghana, where we overall have low rates compared to something like the US or the UK, we still see a high mortality. But in general, we see that, women breastfeed years. I mean, they have on average 5 children, which is, not that common anymore in the UK or the US. And so these demographic changes are going to change the types of breast cancers that are likely going to arise as we go on. One of the things that we've just started, we haven't published it yet, but one of the interesting questions that we have been having, and I think is a big debate in the community of breast cancer, is whether or not breast cancer in Africa is different from that occurs in European populations. Are there genetic or biological or environmental factors that might actually be different? And I was actually skeptical. I wasn't sure, So many African Americans actually come from Ghana, and genetic, in terms of genetic ancestry, unfortunately, because of the slave trade. But whether or not we would see a similar in the incidence of the different types of breast cancer for ER negative and ER positive breast cancers was a big question. And we actually have data now, because we did a population-based study. We actually were able to get back the rates.
Oh, you were able to get raw data.
Yes, so we were able to estimate the rates of the types of breast cancers that are occurring in Ghana. Because one of the things that's very important is looking at the frequencies of breast cancer is not enough, because Ghana is a very young population compared to the US population. And if you were just to compare the frequencies, you will get led astray. You need to look at the rates and adjust for the age structure of the population in order to really say whether or not there's a similar or a different incidence rate. So we were able to do that, and we're working on the paper right now, but we're actually seeing that the rates of ER negative breast cancers are similar between African Americans at the same time. So they're slightly higher in African Americans, and I do wonder how much of that is due to differences in risk factor differences, so less breastfeeding.
And their livelihood as well.
Exactly. Exactly. Yeah.
But I just want to hold that for a minute, because
Sure.
people talk about BCRA1 being great repairing genetic genes. They talk about it a lot, but yet the two of them, BRCA1, BRCA2, there's some sort of. Can you just explain that so that
Sure.
students and we can understand the link between these two?
So this is historical. In terms of breast cancer, these were done in linkage studies where they're looking at, trying to within families that had a high incidence of breast cancer, they tried to determine what those genes were that actually were associated with risk. And Mary Care Kling was one of the key people who started some of those efforts. But Doug Easton, actually, who I work with, who's part of the Breast Cancer Consortium, is another person who found these genes, BRCA1 and BRCA2. And in Ashkenazi Jewish families, it's been the historical families where they were identified, but it's been found to be also associated with certain mutations within the BRCA1 and BRCA2 are associated with risk. Interestingly, BRCA1 mutations are associated with ER negative breast cancers, and BRCA2 mutations are associated with ER positive breast cancers. And we actually are looking at that in Ghana as well. Currently, we have no evidence to suggest that the risk is any different from what we see in other European populations. So we are curious, is there other factors or other genetics that might be, related to breast cancer in Africa?
Well, there are some studies that suggest that you're substantially more likely to have a genetic mutation linked to breast cancer if you have blood relatives, grandmothers, mother, sister, aunts on either your mother or your father's side who have breast cancer and diagnosis before age 50. There is both breast and ovarian cancer on the same side of the family. You're more than likely to have it. You have relatives with triple negative breast cancer. There are other concerns in the family, such as prostate, melanoma, pancreatic, stomach, any sort of other sarcomas. And also, if you are Black and have been diagnosed with breast cancer at the age of 35 or younger, a man in the family who's had breast cancer, and any known abnormal cancer gene in the family. Would you agree with that?
Definitely. I don't know if the clinical colleagues have anything more to add.
Yes. At this point, Dr. Beatrice, welcome back. Can you? We just talking about the genetics aspect of it, and how that plays a fundamental role. And what I would like to see in the future, coming back to you, Dr. Figueroa, is that pharmaceutical companies and medicine on the whole start to treat people based on their racial background rather than just giving medication and treatments, and for the information that you just shared. Dr. Beatrice, would you shared some important information last time that made us Black women think, wow, what is this? You're saying that we should have our mammogram at a much earlier stage, because here in the UK, as you know, Dr. Rami, when do we have our mammograms? We think to ourselves we should have our mammograms in our over 45, and suddenly we could be diagnosed much earlier than any other population, racial group here. What do you have to contribute to that, to say? We can't hear you.
Oh. And sorry, I said in the UK, the NHS program for breast screening, when it started for the period of the age between 50 and 70, then rolled out to expand a little bit this age between 47 and 73. And just recently, there is a publication now for the UK that to expand even the screening for even younger to age of 40 now. Now, but the difference here is because the health system here is in the UK is free of charge at the end point, where like in the United States, it's paid by the individuals. So they have the breast screening program start there at age of 40. And many countries now started to implement this change to start it at age of 40, because I think myself noticed this when I moved around between breast units, that we're getting now much younger patients diagnosed with breast cancer, not only 40s and even 30s. And as everyone know here, when you have breast cancer at age of 30, that tends to be triple negative, tends to be very aggressive, tends to be advanced even in the early diagnosis. So it's very important for the viewers who listen or watch us that to make sure that patients, come with any symptom is taken seriously and assessed by the specialist.
Okay, thank you so much for that. That gives some clarity. Dr. Figueroa, just wanted to ask you about what is your next step in regards with Dr. Figueroa? Is she there? I just want to ask her, what is her next step in regards to the studies that you are doing? What is the next step for you? I know you've been around the world, you've done significant amount of research, and and I know you're still embarking. What is the next step? What do you think you would like to see that is going to help shape the treatment, the care for breast cancer patients?
Yeah, well, I think you alluded to it earlier in terms of getting more. I mean, we need more participants. We need more studies done in diverse populations, and that includes Indigenous African populations, as well as many other, lower middle income countries. My family is actually Hispanic heritage, and we are mixed up racially from everywhere. So, I mean, and we are poorly represented in most studies. Currently, though, I think in terms of understanding the biology of breast cancer, I'm quite interested in understanding and teasing apart. We're seeing quite distinct differences in the incidence rates, even within different parts of Africa. So South Africa doesn't seem to have the same patterns of the types of breast cancer we see that we're observing in Ghana, for example. And I don't think the same exists in Kenya as well, where we're starting a new study with colleagues there. in Nairobi, as well as in 2 other places in Machakos and in Kijabi.
And also
Hospital.
in Rwanda, because Rwanda as well has I don't know if it's, I think one has to question whether it's a low diagnostic rate or whether it's just there's a low incidence. You know whether it's underreporting in the context of presentation, and therefore or is it that it's just incident rate?
You're getting to the point that it's a complicated situation, especially when you're dealing with LMICs, because when it comes to LMICs, you're dealing with the issues of healthcare access. So I used to be living in the US, so I completely agree with Dr. Rami about the issues of healthcare. Having healthcare and access to healthcare is a huge, important issue. So we can't get around that fact. But on top of that, there's potentially biological differences, and I'm not sure how much those will explain things. We still need to understand what is the biological versus the healthcare. But healthcare access is a major contributor to a lot of health disparities around the world, and it would be the place that you'd really want to start at in terms of trying to improve, I think, outcomes for the patients. Getting the best care is the number one thing. But for the triple negatives and the ER negative breast cancers, they still contribute to a large proportion of the mortality. And the fact that we see more of those in African ancestry populations is an important problem that we haven't solved. And studying and doing research in these communities could actually give us some new insights into what might be, important new targets for treatment.
Yeah. So thank you for that. I want to throw a question for all the panelists right now. Yeah. We're talking about breast cancer. We're going to come to the other factors, but it said weight is a significant contributor. Alcohol, smoking. There's a whole list, but when you look at those lists are also contributors to other illnesses. It doesn't only breast cancer. So therefore, it is really, one would say, okay, this one, you're obese and you're more highly likely to have breast cancer, or, some of the indicators that you see that is published is very generic. What do you say, Dr. Samuel? Would you agree?
Yeah, I mean, I have had women who have had 5 children and have stage 3 disease. I've had, so while the advice makes sense and it probably is correct, I'm not quite convinced that those, the alcohol and the obesity and so on, I am not entirely convinced. I wouldn't change it, but certainly my experience has those are not factors that I really pay much attention to, be perfectly honest. What I can say is that, after 30 years, I can tell you the persons we are diagnosing, certainly at the Cancer Society, because we offer the only sort of organized screening process in Trinidad. I'm telling you, the number of women in their 40s and 30s is remarkable. We've had 2 28-year-olds. I've had a 28-year-old with stage 4 disease. I've had a 35-year-old with hepatic and lung metastases with a 2-centimeter primary tumor. So the biology, what I am concerned about, well, I shouldn't say concerned, but what I am fascinated and interested is the biology, which is why I'm thinking, Dr. Figueroa, I would love to collaborate with you for what we do here in the Caribbean, because one of our issues is that there's a lack of. This is
the reason, Dr. Samuel, that I do this platform.
Yeah, absolutely.
Because I want that cross-national, cross-international learning.
Absolutely.
And not only that, one of the things that Dr. Figueroa said is about getting that rich source for the trials. We need people to participate. And therefore, in order for us to have better treatments, better outcome, we have to understand the data. We got to understand where it's coming from so that we can do that promotional work. Dr. Rami, what do you say? What do you say about this?
I was just trying to allude on the risk factors you mentioned. I mean, it is a complex issue. There are facts that we can't ignore. We know breast cancer is mainly in the gender of women. We can't ignore that. We know it happens more commonly with age. Yes, I say that we're seeing young patients. However, 75% of patients are at above age of 50. So age and, the gender, we know that. And then there are then the combined genetic environmental factors that studies with no doubt show that there is evidence that these are factors play a role in resulting in breast cancer. So we mentioned the obesity or overweight, and the reason of that, that the peripheral fat tissue in the body will increase the production of estrogen hormone, and even when the patient their ovaries stop producing this, so the peripheral fat will do this. So the study showed that if there is increased volume of this fat, that in turn will increase the production of estrogen. So we can't ignore that. I mean, this is one of the factors. Yes, it's complex. We can't get a point now to say this is what caused breast cancer. What we can say, it's how common it is, and it's very important to have the screening schemes in all countries, because it's a simple procedure where patients can go and have the mammograms done and then pick up the cancer at early stage, and then we can reduce the mortality rate. This is my point I was trying to put out.
Okay, and thank you so much. Dr. Figari, what you'd like to say to round up this? I am so pleased that there's going to be some cross international learning in regards to this. I'm super excited by that. So at this moment, we will go straight over to you, Dr. Rami, to do your presentation.
Right. So I'll do a presentation now about oncoplastic procedures. Let me just share my screen. Just bear with me.
Dr. Figueroa, thank you. That was very informative. And I certainly looking forward to read all your literature and your findings.
Yeah. I was just going to say one thing as the epidemiologist in the room. I was going to say the thing about risk factors is that on the population level, they're very good, because you're looking at, large numbers at the population. What we do have a challenge on is at the individual level. And that is, we can never, nothing is, these are probabilities. So we can't ever explain, everything, only the proportions. And so it is a difficult thing, but understanding the risk factors, and with breast cancer, there's so many risk factors with very small effects. And so sometimes it's this accumulation of all of these risk factors together that may or may not increase your probability, but it's never a definite thing. So that's the unfortunate challenge with epidemiology.
Before we start the presentation with Dr. Rami, we will take a little break. This is Michaeline Holder-March, the CEO and the founder of MHM Health Consultancy and MHM Roundtable and Leaders Health and Tech that we hold every year. And we are really excited to be partnering with Savvy Media Group, Video and Index, and Convenus, who are our partners in regards to this webinar. So thank you so much. We're going to take a short break. Hi, I'm Michaeline Holdermarch, and I'm so excited today that we've had so much information about genetics. We had so much information about the stages of breast cancer, and there's so much more to come. Due to technical difficulties, Dr. Ade Waife is unable to join us via video, but however, she would be there to actually be able to explain and give us insight using audio. But now we are so pleased we are going to be hearing from Dr. Rami Tabak, who is one of the UK well-known breast surgeon, oncologist, as I should say, for plastic surgery and doing amazing work. Thank you. And I hand the floor over to you, Dr. Rami.
Thank you, Michaeline. Just to start to say that, I mean, when we talk about breast cancer treatment, so breast cancer treatment can be either local, regional treatments or systemic treatments. So after patients been diagnosed with this, it depends on the biopsy, which I have to stress needs to be done percutaneously. We stopped doing now excision biopsy from the lump by general anesthetic, so we can do it now under local anesthetic. So patient comes to the theme clinic called One Stop Clinic, where patients have the clinical examination, then the radiological examination, and then pathological examination, and they do the biopsy. And then the biopsy results tell us what the cancer is, what cancer is about. So treatment of this now is local regional treatment by doing mainly surgery and then all systemic treatment. And now there's increase of evidence that we use systemic treatment to start with by giving chemotherapy to the patient for the sake of shrinking the size of the tumor, and then allowing the cancer can be treated with conserving surgery and preserving the breast. So this is the theme of what we call it oncoplastic surgery. So I'm not a plastic surgeon, I'm a general breast surgeon. And in the UK, we pioneered in this idea for the last at least 10, 15 years, where general surgeons try to learn the skills of the plastic surgery on the breast. And they are able now to remove the lump or the cancer to some extent, how big it is, and keep the shape and the mound, the shape pleasant to the patient and achieving high satisfaction rate. So oncoplastic surgery means, as I mentioned, integration between the oncological aim to remove the tumor backed by a synthetic method to reshape the remaining breast volume, which is accepted by the patient, and it allows to perform wide local excision or lumpectomy without disruption of the shape and natural appearance of the breast. So in history, it started in the 1990s by Odrich, suggested this integration, and then after that, with other studies, started to be referred as oncoplastic surgery. There are two main types of oncoplastic procedures. There's a volume displacement techniques and volume replacement technique. So it depends on the size of the breast cancer, in the size of the breast itself. As we know that we categorize breast size in commonly to cup size from A and going down to letters, mainly A, B, C, D, and E, and F. So if the breast size is large enough relative to the size of the tumor, then the surgeon will be able to preserve the breast and remove the cancer and do some displacement procedure. So that means just bring the tissue from around the cavity of the tumor where it was removed, and then reshape the breast. However, if the breast is, sorry.
Excuse me, Dr. Rami,
yeah.
Can you kindly just put it on full screen? Because some of the people are texting me to say they can't read your slides for a minute.
Is it better?
Excellent, thank you.
Yeah. So if the breast is small, especially in the eastern part of the world, in Japanese, Chinese, Vietnamese, and Korean countries. It would be more appropriate is trying to camouflage the shape of the breast by replacing, by bringing some sort of what we call it flaps. So flaps mean bringing the own tissue of the patient to fill the gap and correct the defect. So I mentioned here some few of the procedures. In volume displacement, basically, we all know about breast reduction procedure, or called breast reduction mammoplasty. So if we can utilize this procedure in a way to remove the cancer and reduce the size of the breast, then we call it therapeutic mammoplasty. So we do reduction in a way to treat the breast cancer. And there are many types of therapeutic mammoplasties, and I'll come across slightly later. And then for volume replacement, there are different type of flaps. I just put here adipofacial flap, lateral thoracodorsal flaps. I mean, this is very detailed for breast surgeons to learn about. The famous one is latissimus dorsi flap. I'll come to that. And the more recent now is the thoracodorsal artery perforator flaps, where we use the intercostal muscles artery flaps. Mennos used this classification is to classify the defect in the breast. So he put out 3 types, depends on the size of the breast. So if the breast was small without ptosis, he put type 1, and then within that category, he classified it into 3. I thought he mainly 2, involving A, where there is a minimal defect of the breast following removing the cancer, and then this can create distortion, not much distortion, because the tumor, if it's resected, then the defect will be between less than 10 to 15%, where type 1B, where the defects will be between 15 to 40% of the remaining, of the volume of the breast. And then type 2, where the patient breast is medium size, means like C-cup size, and then it's been categorized again the same categories from the first type. And then type 3, where the breast is quite ptotic, large breast like F or double D or G or H sizes of breast. So this is the third classification, the third category. And here, if you can see that between the 3 sizes, Mennos put here some common procedures to try to close the defect. So in the smaller breast sizes, he used the breast advancement flap, which called it BAF, to close the defect if it's less than 10-15%. And this was on the smaller defect. If it's slightly bigger defect on those small breasts, he used latissimus dorsi myocutaneous flap, and I'll mention that later. Where in the bigger breast, he used more different type of flaps and breast reduction. And this is a picture of the breast where the tumor is on the lateral aspect. This is the side of the breast. And so he took out the skin as well as the underlying tumor and closed it from raising, if I move the coda, from raising the skin at this area here and rotating this, flipping over onto this defect and closing this primarily. Now, South Korean surgeon Yang, again, they had small to moderate sized breast women. He used different classification, and he categorized the procedures into, or the classification into small, moderate, and large. And he put the benchmark between moderate to large if the tissue to be excised is less than 150 grams or more than 150 grams. So he put here volume displacement for small defects by using the advancement flap. And then for the medium size, he used these flaps. and replacement if it was larger defect, sorry, then he used the replacement flap. Then Mehdi Rezai et al. Mentioned another way where he used his classification based on the location of the tumor. So not only the size of the cancer relative to the size of the breast, it's also that the location of the tumor. So if we divide the breast into 4 quadrants, so the 2 inner quadrants, which is close to the breastbone or the sternum, and the 2 lateral quadrants, which is close to the side of the patient. And cancers occupy the bottom part of the breast, which is the inferior aspect, and the inner part. These are the not forgiving areas, and they can cause deformity following the surgery and following radiotherapy. So that's why we tend to be very careful when we resect these tumors, not to leave the patient with deformity. So in the upper part of the breast and unicentric for the ones who don't know this term, unicentric means if it's 1 quadrant, so 1 out of 4. If the cancer is in 1 quadrant, that means it's within that quadrant or on the top part. So Rezai here used the glandular rotational mammoplasty, where you can bring the glandular tissue from both areas. And I'll put a picture in a second. And where if the tumor is expected to reduce or to excise more than 20% of the breast tissue, or if it's more than 1 quadrant, although some surgeons will argue here that if the cancer is more than 1 quadrant, the patient will need to have mastectomy or removing the breast. However, you can get away with some sort of reshaping by doing some replacement flaps or doing breast reduction. So this is what Rezai put here. So you can see here the cancer is in the bottom part. So after he took the cancer, he brought part of the tissue here, lift it up. This is another one called thoracoepigastric flap, where the scissor here. So he lift up the skin and de-epithelialized, mean remove the epidermis and left the dermis with subcutaneous fat and the fascia, and brought it here to close the defect. Here, lateral thoracodorsal advancement flap, and here breast reduction. And this is the latissimus dorsi, and I'll describe this in detail. Then most of the talk is about Krishna Clough, Parisian surgeon from France, who devised an atlas, basically atlas, and a very good work Krishna Clough has done. He devised an atlas, means each quadrant of the breast, he put there 1 or 2 procedures for the breast surgeon, oncoplastic breast surgeon to do. And he mentioned here not only 2 factors. The first factor is the location of the tumor, as I mentioned, and the second one is the amount of breast tissue you're removing. The third factor Krishna Clough put here is the glandular density. So if you have 80 years old lady who had fatty breast, and mobilizing breast tissue in a fatty breast can give tissue necrosis, which is not good sequelae of the operation. Where in a 40 years old woman who have glandular breast, you will be able to mobilize the breast freely to close the defect. So, and he mentioned here the dual plane. So when we lift the skin up out of the breast tissue and then mobilize the breast tissue from underneath the muscle, so you did dual plane dissection here. So in a young woman should be able to tolerate this without tissue necrosis. So Clough devised 2 types of oncoplastic procedures. Level 1, which doesn't need advanced training, and called level 1 oncoplastic procedure, which is done if the surgeon expects or estimates that he or she is going to remove less than 20% of the whole breast volume. So this is called level 1, which is smaller operation, and level 2, if the surgeon estimate that the resected breast tissue will be between 20 to 50%, and this requires advanced training. So this is level 1 oncoplastic procedure, where the cancer is only removed and then brought and closed by surrounding tissue. So first of all, you make the incision, you mobilize around the area by, you mobilize the skin. If you can see the all arrows here, then the cancer is removed, and then that resultant cavity is actually filled by the two, this area and this area, or this area and this area, medial and lateral in this picture. And the nipple itself is mobilized, then it does stop from deviation of the nipple after the radiotherapy. And this is how you see it on the breast. So this is the cut is there as well. And so the nipple has been, what we call it, re-centralized to stop it from deviation that way following the surgery, because there's always a reaction to it. So he put this atlas, and this depends on the quadrants. So quadrant, if you look at the left breast, and starting, as if I'm looking at the breast, as if like I'm looking at clock, the clock. So 5 to 7 o'clock, which is the lower, the bottom part of the breast, we can utilize these procedures, the mammoplasty with superior pedicle. If it was in the lower inner, and this is not forgiving area, we can use superior pedicle or V-shaped scar, and mammoplasty, and I'll show a picture of that. If it's 9/11, upper inner quadrant, bat wing procedure, and if it's on the top part of the breast, we can use breast reduction. However, the pedicle of the nipple is on the bottom part. Then in the upper outer quadrant, we use the racket mammoplasty, and I'll show a picture of that. And then lower outer quadrant, superior pedicle mammoplasty. And if it's in the central, where the nipple is removed with underlying cancer and then closed by mammoplasty. So this is lower pole. So the cancer is there, and this is the marking and the cut. So this area is excised. The nipple is moved upwards, as you can see, moved upwards, and then that tissue all removed, and this one and this one brought together to close the defect, and we'll end up with this. This is called wise pattern inverted T-shaped scar. This is the lower inner. This is lower inner, or 7 to 9 o'clock position. The cancer is here. So the cancer is removed with the skin, and then that cavity or defect brought actually from this part of the skin and the fat. So brought all the way there, as you can see with the arrow, and then closed this way. This is called V. Why it's called V? Because that shape V, mammoplasty. This is top part or upper pole breast cancer. So this is the cancer. This is the area is removed, and then this area excised, and then the tissue moved upwards there and closed from here to there. And this is round the block, which is very resilient, good procedure. I would advise even breast surgeons who don't have much training to learn this. Basically, you make two, like a donuts, incision around the nipple areola complex, and then you make incision here. You remove the cancer. Basically, you need to mobilize the skin freely, and mobility of the skin between a quarter to 2/3 of the skin volume. So after you mobilize, you remove the cancer, then what left of the tissue you brought together and you close. This is the racket or the upper outer, where you remove the skin with underlying tissues, yeah, and then close this together. And this is the lower outer one. This is called the J-shaped one. To do the same. So what are the advantages of oncoplastic procedure? It enables the surgeon to expand the indication of breast conserving surgery without compromising the oncological aim in a good result. Avoid the need for delayed reconstruction. Why? Because sometimes if patient comes back after radiotherapy not happy about the procedure, and then you need to camouflage it and send it to the plastic surgeon, and the plastic surgeon will do flap. So by doing this immediately, you avoid this reason. And the studies showed, and I put here the references, the study that 298 case cohort 5-year recurrence-free or overall survival rate was 93% and 94% respectively, which is good. Complications: by moving the breast tissue, especially if it was fatty, you will end up having tissue necrosis, and this is one of the complications. Wound healing problems: as you can see, you have a large wound, and sometimes with non-good selected patients, you might have delayed wound healing, like diabetic people or smokers, or sometimes further surgery. Because when we do this operation and send the tissue off and we close, and if we found out that the cancer is not centrally in the specimen and the patient has involved margins, sometimes we cannot go back simply and remove the more margins because the complex of the surgery. So the patient needs to be counseled preoperatively that they might expect in about 20–30% of cases the risk this might happen, and sometimes the patient will need to have mastectomy. To conclude, so this option of oncoplastic procedure, which is called the third option between lumpectomy and mastectomy, it's a new way now, and it's increasingly evident it is safe. And the PROMS studies done on this, which is outpatient reported patient report, showed it's very good result, and we should be able all to learn this.
Okay, thank you.
Thank you very much.
That has been extremely informative. We welcome back Dr. Beatrice Waife Ade here. She's going to be on speaking. Can you hear us, Dr. Beatrice?
Yes, I can. Yes, I can hear you well.
Excellent. Did you hear that? Did you hear a bit of that presentation?
Yes, I did.
Any comments?
Excellent.
Any comments? What about that procedure? Is it being tried in Ghana, or Dr. Malcolm, Dr. Samuel? Is it being tried in Trinidad?
Well, we do have one oncoplastic trained breast surgeon here, but he only works in the private sector.
Ooh,
so it's not available to the general public. I mean, I do some rotation when I do. I tend to do a lot of wide locals. I did my first mastectomy last week after over a year and a half. So I'm not oncoplastic trained as Dr. Rami is, but I do mobilize, make some flaps and so on, and try to get a good picture. And I think it works. Many women here, you'll be surprised, they will tell you, Doc, please take it off.
Wow.
We still have a cohort of women who believe that if you don't do a mastectomy, it's not done properly. That's a cultural thing. Some of them know somebody who has had a lumpectomy and it came back. So no, they don't want that. They want to have a mastectomy.
Wow.
Yeah,
I will come to Dr. Beatrice. Dr. Beatrice, what's your opinion on this?
So, hello. Yes. Obviously, if you have an early stage tumor, early stage breast cancer, the surgery of choice is a lumpectomy and not a mastectomy. But most of the cases, because they are being diagnosed late, you are not able to offer them the lumpectomy. And lumpectomy sometimes, in some setting, they think it's equal to the kind of lumpectomy that is done for fibroadenoma. So in developing countries, we have to come clear on the fact that if you want to do a lumpectomy or a wide localization or a radical resection of the tumor, it should be about 1 centimeter from the tumor itself. So if you are not able to get that distance, then probably you cannot do the breast conserving surgery that you want to do for the patient. And there are pros and cons. I mean, there are kind of contraindications that we need to also bear in mind. Like if the tumor is more than 3 centimeters, then you may have to downstage it by giving some neoadjuvant chemotherapy to arrive at a smaller size to be able to offer that surgery. But because sometimes we don't take the necessary precautions, then the tumor can recur. But if we take the necessary precautions, the tumor will not recur. And we have, like when you take our breast cancer survivors, you have quite a chunk of them who had breast conserving surgery years ago. And then you have the mastectomies. So if you are able to have a good local condition, I'm very sure you can then do a wide local excision or a breast conserving surgery. The issue about plastic surgery is something that we need to talk about in the developing world, because we are always getting bigger tumors. It's not easy to have a good cosmetic picture after your surgery. But if we had more plastic surgeons available, then they could come in hand to assist the general surgeons to present a good, picture, a good, scar after the surgery. But most women would prefer breast conserving surgery rather than mastectomy. And sometimes they will tell you that you leave me a little bit of the breast, and she's happy with it. But we also have to explain to them that if you want to benefit from a breast conserving surgery or a lumpectomy, then you have to go to the hospital early, but not stay until the whole breast is engulfed with the tumor.
Can I also add that one of the problems with some of the smaller countries in the Caribbean is that they have no access to radiotherapy, because if you do breast conservation, you have to have surgical radiotherapy. So what happens by default? By default, in some of the islands, patients have a mastectomy simply because there is no access to post-surgery radiation. And they will, even a stage 1 or stage 2 tumor, which, it's something that I am really appalled at, but it's the reality of the situation.
If you don't have radiotherapy, you can't do any of these procedures, and you need just to embark on doing mastectomy. This is simple as that. So unfortunately, yes, you need to have a backup of adjuvant treatment to reduce the risk. By the way, Dr. Beatrice, it doesn't matter how big the tumor is, as long as we have surgically excised, clearly excised surgical margins, and with radiotherapy to help. So the recurrence should be just the same, because sometimes you get 3 centimeter or 4 centimeter cancer, but you have big breast as well. So it doesn't affect the cosmesis of the breast. As long as you have surgically clearly excised margins and radiotherapy given and systemic treatment where applicable, it doesn't affect the recurrence rate.
Okay, well, I think that has been really informative. I would like to thank you, Dr. Rami, for that. Before we go across to Dr. Samuel, we will come back to Dr. Beatrice, who will go into about the positive and negative sides of conserving surgery versus a mastectomy. But first, we will just like to the attendees and people who are viewing on YouTube and everywhere, for them to be reminded of who you are. So we're just going to take a quick break so that we could pull up the slides so they're reminded of who you are. Thank you so much for sharing, and thank you so much for all who is watching. This is a really exciting series. This is Breast Cancer Care and Cure by MHM Health Consultancy. And we would like to take a quick break. Thank you. Hi, welcome back. I'm Michaeline Holdermarch, the CEO and founder of MHM Health Consultancy and the MHM brand. First, I'd like to thank our collaborators, our partners, Video Index. If you are looking for quality video production, really in regards to your training and development, in regards to making that sort of really health promotional packages, please contact Video Index. You'll be able to see their details. You find them on Google. If you're looking for that marketing media kit, reach out to Savvy Media. They are there. They're based in the US, but you will get really a modern kit. I want to thank my other office, which is in Ghana. I'd like to thank Team Ghana, Rebecca Osei, who is the general manager for Ghana, and also Henry Badger, who does such fantastic graphics for us. We like to also thank our independent consultant, Tricia Z. George. And by the way, for Video Index is Mr. Manuel Hassan, who is the CEO of that company. And for Savvy Media, it's Miss Melissa Ambers. But we like to also thank our new partner, Convenus. They are an international biggest event provider for health care, social care, and public care. And it's actually looking at all the different platforms and looking at case studies. And it's awesome to be able to partner with them. Right now, we will go across to Dr. Beatrice Wife, who's going to talk about prevention. So Dr. Beatrice, prevention, cancer prevention, breast cancer prevention, is that at all possible?
Yes, thank you so much. And I want to welcome all the people from Ghana and across the world who have joined us in this October. And October is the Breast Cancer Awareness Month that we are keeping a lot of women on their toes by doing free clinical breast screening for all women who enter the Peace and Love Hospital and want to be screened. So we always say that prevention is better than cure. So can we really prevent breast cancer? We still do not know the primary cause of breast cancer. So we cannot have the primary prevention that we would like to talk about. Eating healthy foods, staying fit, not taking too much alcohol, not smoking, all these factors are very, good to make sure you don't indulge in them, in the negative vibes. But somebody can stay without drinking alcohol, without smoking cigarettes or shisha, keeping fit, eating healthy, and yet can still develop breast cancer. So what we are saying is that we cannot do primary prevention, but it's important to note that we can do secondary prevention. So it's essential to schedule regular breast cancer screenings. We in the developing world, we don't have the systematic screening mammography, for example, that is done in the developed world. We don't have it. But it doesn't mean that we should fold our hands and wait for breast cancer when it has already stricken and for it to kill us. So we have to advise our women to do their own breast self-examination, because in settings where they have screening mammography, they are diagnosing non-palpable lesions. But since we don't have the system, we are seeing cases that are big. And it's only when the woman makes a conscious effort to examine her own breast every month, knowing her own breast, how they look like, how they feel like. That's the only way by which a woman will notice an abnormality with her breast. We don't want women to be doing this breast self-examination as sporadic events or and have incidental or accidental findings. The earlier a malignant tumor is detected in the breast and prompt action taken, the greater the chances of a cure. So early detection and prompt action is the best protection, is the best protective tool that we have. And in an area where a lot of women cannot read nor write, like in most low and middle income countries, we need to send a message to our women wherever we find them in the dialect that they can understand.
So, you know, as you talk about that, what is the age you think we should start pushing breast cancer self-awareness?
I think if you come to settings like ours, in the upper junior high schools, we should not wait until they get to the senior high schools, because we still find cases in the young ladies. So if we start educating them early, they will grow up with the knowledge. They will also help us to educate their mothers, their aunties, their grandmothers. And by the time they grow up, they will not believe that breast cancer is caused by witchcraft, as it pertains in most low and middle income countries. They will not believe that it's a spiritual disease. They will understand that it's a hospital disease. And as we educate the women, we have to also consider the barriers that they have to overcome in having breast health care services. The lack of awareness, inadequate or bad treatment that can occur, the cost of treatment, the fact that poverty is an issue and it stares in the face of everybody, the distance from where a woman resides and where she can get treatment is always an issue in the low and middle income countries. Sometimes a woman has to travel for 6 hours, 7 hours before she can have a mammogram done. That is not acceptable. The lack of counseling. And we always say that when you are ready to treat cancer, breast cancer, you must be ready to have a counseling service or a counseling person, a psychologist or a counselor to be in place. And the lack of support, most often from the spouses. Sometimes a husband will divorce the wife because the wife has been diagnosed with breast cancer. And this is all because of the lack of awareness. And so we need to,
yes, that's a good point. But, you know, as we were saying about in schools, and we will come back to that. We'll come back and talk a lot more about that social aspect in regards to that. But let's get back to the clinical aspect of that. There's a lot more for health professionals to do and a lot more for hospitals and healthcare providers to do in regards to how we interact with people of different background, if they're, you know, and economic as well as language barriers, and how we actually inform them about
So the woman herself,
there must be a better way of us actually training ourselves in how we actually interact and what is that person's social situation. Who do they have to give them support? Do they really understand what it is you've told them? Because for some, just hearing the word cancer, not the breast, but hearing cancer, could actually trigger a sort of like, this is the end for me, when there is so much different types of treatment that may be possible.
Yeah. So after the woman has been taught how to examine herself, we should also talk about clinical breast screening. And that is done by trained personnel. In the low and middle income countries, we have a lot of community-based nurses. We have a lot of nurses in the periphery, in the districts, in the chip compounds. And these nurses can be retrained as to the best way to examine a woman's breast. And so if a woman is doing her own breast self-examination every month, then we would advocate for a woman to be clinically screened once every year. Because we don't have a system of calling them for screening, we could train the nurses to learn how to properly clinically examine the women. That is what we have at the moment, and we have to make good use of them. And then after that, we should talk about the importance of mammography and ultrasound. If the woman is younger, an ultrasound may be the organ, the investigation of choice. But in the Black woman, we advocate for starting mammography from age 40. In Europe, it started at 50. But breast cancer, we know, starts earlier in the Black woman. So the Black woman should not sit for until 50 years before she will go for her baseline mammogram.
Yeah.
The Black woman should start from age 40. And if there is a positive family history, then that baseline mammography could be started from age 35, using ultrasound as a complementary investigative tool. So even where the woman is doing her mammogram at the age of 40, ultrasound should be added to it.
Thank you, Dr. Beatrice. That is just so informative, and I think at some point we must do a series on prevention methodologies and all the different programs and promotional programs that is necessary. Any questions for Dr. Beatrice before I move on to Dr. Samuel? Any questions? Because Dr. Samuel, it sounds similar to Trinidad in some contexts.
Well, I mean, the Caribbean, because as I pointed out, we do have variations in accessibility, variations in service, variations in treatment. So we certainly at the Cancer Society in Trinidad, and I think reflected in Barbados and Jamaica as well, is that we start offering screening at age 40. We do clinical breast exam, mammograms, and ultrasound. There are MRIs available in case of high-risk patients who prefer to, who sometimes patients with, with 3 or 4 relatives. Having access to BRCA testing is expensive, so individuals who can't afford it, unfortunately, we sometimes suggest that they can do early MRI to see if there are any changes. But yeah, it's a matter of awareness. I mean,
it comes back to what, hello? It comes back to what Dr. Figueroa was saying about access, the accessibility and the economics around it. Dr. Tabak, this is a great opportunity for you to go across the Caribbean and Africa and share this incredible knowledge and train up a few people. I'm sure they're going to welcome you to do a visit, a cross-international visit. Just get me a little suitcase so I can come along. That's all I ask. Dr. Samuel, are you ready to actually present?
Well, I just have a little short thing here. It's just a little information about what's happening in the Caribbean. Nothing clinical really, but
Okay, that's fine. We will just pull up your slides so that people know a little bit about you. Again, would like to thank everyone who participated. This has been such a wealth of information. Clinically, we also have some shared learning, health promotion, and also about training and development. And we identify that there's a lot of training that needs to go across the board, and also some discrepancy between when you actually would do that incision. So watch this space.
All right, let me see.
We have a quick break. We're going to take a quick break, and Video Index is going to give us a quick break. And we're gonna, by the time we come back, Dr. Samuel, you'll be ready to present.
Sure.
Well, we are back again. Again, I'm Michaeline Holdemarch, and I am the founder and the CEO of MHM Health Consultancy. And I'm here with my partners, Video Index, Convenus, and Savvy Media. And we welcome Dr. Malcolm Samuel. Could you kindly put it on full screen so we can see your presentation? Thank you.
Are you seeing it at the moment?
So just hit full presentation, full screen, and we'll be very happy.
Full screen. Where? Are you seeing it?
Yes. So all you need to do is go to slideshow, right to the top, right up, go across slideshow. That's it. And from beginning.
From beginning.
Yeah.
Okay.
Excellent. Yeah.
How is that?
That's okay. Go ahead.
Great. So just a little information on what's happening in the Caribbean. So as it's titled, Breast Cancer Care in the Caribbean, and a little subtitle, Not Where We Should Be. So just a little bit of geography. We are a distinct region within the Americas. The Caribbean often refers to an archipelago of islands stretching from Bahamas to Trinidad, and also includes, because of historical reasons, countries on the Central and South American mainland. So you have Guyana, Suriname, French Guyana on the South American mainland, and Belize on the Central American mainland. Many of the islands, we share strong historical ties due to European colonization and the transatlantic slave trade. There's a diversity of languages in the Caribbean. You've got 4 main languages: English, Spanish, French, and Dutch. And as a result of this, there is a diversity of languages, cultures, political systems, and socioeconomic conditions. And these impact on what happens in terms of accessibility to services. For example, the French, so Martinique and Guadeloupe, which are departments of France, their health systems are actually quite good. Dominican Republic versus Haiti, on the same island, but there's a glaring contrast between what's available there and what's available, you know, in terms of Haiti versus the Dominican Republic. And Puerto Rico is as part of the US. This is just a quick little picture here to show you what we're talking about. So just a few rough and quick statistics. PAHO, which is the Pan American Health Organization, which is the WHO regional organization in the Caribbean and North America and South America, has shown that in 2015, last data available, cancer accounts for 20% of deaths in the Caribbean region. Breast cancer is the leading cause of death in women in the Caribbean region, ranges from 14 to up to 30%. So in some countries, 1 in 4 women in their lifetime are at risk of being diagnosed with breast cancer. Unfortunately, the death rate is quite high. It's estimated to be twice that of North America, from 25 to 30%. And this is because many patients present late, stage 3, stage 4 on diagnosis. Treatment is patchy. As I mentioned before, some islands have no access to appropriate radiation, and oncology services in many islands is mediocre. Availability of key chemotherapy drugs is patchy sometimes, and we have no access to the newer immuno and directed chemo for recurrence and metastatic or advanced disease. National screening programs exist in only 5 countries, and generally refer to about 31 countries within them. We lack quality cancer registry activity, so there's very little data available throughout the Caribbean. There are 9 countries, mainly the larger countries, 1 or 2 of the Dutch countries, and obviously the French dependencies who have good cancer registries. So they provide data on which you can base your treatment and this provision of services in their countries. As I mentioned before, diagnostic and treatment services are often inadequate, costly, especially in the smaller islands. So, as I mentioned before, radiotherapy. For instance, Trinidad has 3 machines, Barbados has none. The next machine is in Antigua, and then Jamaica. Dominican Republic has, Puerto Rico has. So the other islands have no access except if they travel. And of course, individuals, travel is expensive within the Caribbean. Then you have to find somewhere to stay, and there's a cost attached to it. Our palliative care services are undeveloped in most countries. Trinidad in the last few years has 2 hospice facilities, and I know Jamaica has a hospice facility, Barbados, but that's it in the English-speaking Caribbean. There are very few comprehensive cancer plans within the national health services of the Caribbean countries, and we operate. Our healthcare is because of our colonial heritage. It's certainly in English-speaking and French-speaking. Because of the colonial heritage, there is a national type health service where there's a public service paid for by taxpayers, free at the point of access. But often the facilities in those hospitals are poor. The private sectors in some islands, Trinidad, for example, is quite well developed. So treatment outcomes tends to be better for patients with private insurance. So they can access private treatment, they can access private surgery, they can access oncology and radiotherapy. In Trinidad, there is a breast surgical unit, which has a breast surgeon and a plastic surgeon. So over the last 3 to 4 years have been able to provide a level of service. However, because there are only 3 surgeons there, it's difficult for them to cater to the over 200 or so patients who are diagnosed per year in Trinidad. So some patients get what I would consider inadequate treatment in some of the public hospitals. That's it. Thank you. That's just a rough idea of what's happening in my neck of the woods.
Well, it's been very informative, and what I want to say here is that that is so reflective of not only in the Caribbean, in parts. I lived in America as well, and one of the things is this has just proven is that economics play a significant part in the type of healthcare that you would receive and the type of healthcare that you can access. And it's a very sad story, but it's the reality. And therefore, maybe a cross-international hub might be a good start, whereby people can invest money in bringing, skilled personnel like Dr. Rami to come and train up, young surgeons in all this really, less invasive type of surgery, and looking at the genetic aspect of that to do a little bit of education around that. And I know, Dr. Beatrice, you are pro-prevention, and that is so key, because if you don't have the modern day equipment, the technology and all of that, then you have to go back to the manual aspect of that. But before we conclude, and before we come, I just want to go on, because there is something much more significant and that I want to talk about, that lots of people have actually texted me on my phone, and they want to know. It's all well and good, all of this, the clinical aspect, the surgical aspect, reconstructive surgery. That's really all positive. But let's talk about, the recovery phase. That point when a woman starts treatment and she's actually going through a terrible time about the radiology, chemotherapy, tamoxifen, all of that, and the hair loss and all the other things. And even for men, there is some significant impact on their mental well-being. So, Dr. Rami, what do you say to your patients? Because there's a preparation to this. Yes, you've done a fantastic surgery, but there's a post-treatment care plan that has to kick in, because their whole life is going to change.
Very good question. So basically, when we meet the patient and they are diagnosed with breast cancer, there's a team composed of the surgeon and then the breast care nurse. The breast care nurse is trained to look at the holistic approach of managing this patient, not only medically, emotionally, psychologically, and even the surrounding family around the patient. So that's a very important role the breast care nurse takes a part in managing patients with breast cancer. So that's actually journey start from day one, when we break the bad news to the patient when she comes to the results clinic. And then the patient will have a very open access to phone the breast care nurse anytime during their journey of treatment. So after surgery, as you mentioned, and then they have, as I said, open access. If they have any queries or the support will continue. And I hope this will be generalized all over the world. But this is what I'm detailing here in the UK. So any query for the patient with pain, wound healing problems, even when they go to have the post-surgery adjuvant treatment, which means chemotherapy, radiotherapy, again, they will be handed to other nurses who deal with those treatments. So there's always support to the patient in regards to this treatment. And if they have any queries, we give them written leaflets to read about any side effects of like medication, like chemotherapy or even radiotherapy. And then after all treatment finished, they have what we call it treatment summary option appointments. Nowadays, we've been doing this on the phone because of the COVID-19 situation, but used to be face to face.
Yes, save that, because our last question for the evening is about the COVID and your patients. So let's move on. Dr. Beatrice, what is your take on this? Dr. Beatrice, is she there?
Yes, I'm here. Do you hear me?
Yes, I can hear you clearly.
Hello?
Yes, I can hear you.
All right, thank you. Okay, so apart from the nurses who can come in to assist a patient, we also use the breast cancer survivors. We have this unique system where the survivors have been trained how to use their own personal experience to help others. So we have the Hope Project, helping others through personal experience. So the moment the woman is diagnosed with breast cancer, she's kind of handed over to the survivors, and the survivor will navigate her through her treatment journey. She will be checking up on her, calling her on the phone, visiting when necessary, and it has proven to be very effective because they then understand what their friend, their peer has gone through, and it makes the journey easier for them. So that system, whenever feasible, I think should be used to assist the newly diagnosed patient.
Thank you so much. That's such an innovative practice, if I must say, and certainly worth copying. Nothing like patient voices, the power of a patient voice. Dr. Samuel, what about over in the Caribbean? What do they do in regards to supporting that recovery phase, that treatment? You know, what do we have in place, that counseling and well-being?
Well, unfortunately, I share Dr. Rami's. I did my breast training up there, so I am well aware of what he spoke about. We unfortunately don't have that in the Caribbean. What we do have is something similar to Dr. Beatrice, where we have support groups who are former patients. So they will work with the newly diagnosed women to support them, you know, their networks, their WhatsApp groups, they share stories. We do have social workers available as well who will counsel and help. And psychology is also available at the at the oncology unit in Trinidad. I'm not sure, very little of this exists in the other smaller countries. Jamaica has only recently, some doctors in the public service have only recently started up a breast oncology center in Jamaica.
Wow.
So, because they recognize the inadequacy of what has been happening over the years, because of the income disparities, access to, you know, they go to one hospital for a mammogram. There's another hospital where they go for treatment. There's another place that they have to travel to have their radiation. So they are trying to put that together in one unit, which is what happens in the breast units in the UK. We unfortunately have not developed that type of organization with breast care nurses and looking after. Now, I mean, in my other hat, in renal transplant, we have coordinators. So the coordinators look after the recipients after. Now, so each transplant recipient has a coordinator. So that person looks after them, you know, and that works fabulously. So I am well aware.
That may be something that needs to be copied for the breast cancer patient, because I am certain with the figures that you gave before, the support is desperately needed.
Absolutely, it is.
You know, it affects the children, the household, the whole family structure. Dr. Figueroa, do you have anything to say in regards to this?
To my colleagues, I mean, I can only speak as a daughter of a mother who had breast cancer, and I know as a family it's really difficult to watch your family members go through something so traumatic. And we've done a really good job at treating it, but the treatments themselves, if you have to go through chemo, is really difficult. And if there's any way we can hopefully, avoid that for our patients of the future, I'm hoping we can improve the outcome so that, the morbidity issues are just not nearly as severe, because it is a really challenging thing. So I applaud my clinical colleagues. I know they're doing a fantastic job, and the survivors.
Despite the resources that they have available. Whilst we're on that, we don't have much time, but I think it's really important if we could just get a sort of just a quick line. What is radiotherapy? Who would like to answer that? Dr. Figueroa, would you?
Or no, I'll let my clinical colleagues do that.
Dr. Beatrice, one quick line. What is, Dr. Rami, radiotherapy? What is it? What is it?
So radiotherapy is another local regional treatment. It kills what left of cancer cells not taken in surgery. It's a radiation beams, mostly now externally applied. There are new studies now to look at the effects of internally beamed into the wound itself. So this is what is radiotherapy.
Okay, Dr. Beatrice, what is chemotherapy?
Okay, chemotherapy is when we have to use the medicines into the patient, like IV drugs that will go into the system to kind of fight the cancer cells and kill the cancer cells. By in so doing, some normal cells can also be affected. But then it's the most proven and, mode of treatment for cancer.
Okay. And Dr. Samuel, on that note, people take tamoxifen and they take, so what can you say? Someone say, you had to get tamoxifen and you to get radiotherapy, and they are very confused. They're watching right now and they're going, well, why she's getting that and I'm getting these tablets?
Well, what you have tamoxifen is for hormonal treatment. When you are diagnosed, there are three, and you have a biopsy. What we do is we test for certain receptors on the cancer cell. So the most common receptors are estrogen, progesterone, and HER2, which is a growth factor. So tamoxifen works for someone who is estrogen positive. Okay, so it's a form of hormonal treatment. So if you're positive, you can get tamoxifen, or you can get aromatase inhibitors, which are generally given in women above postmenopausal. So you have Arimidex, you have Femara, you have fulvestrant. Those are hormonal treatments. For the HER2, which is the growth receptor on the cancer cell, we use Herceptin. And there are other anti-HER2 drugs which are available, mainly used for metastatic and advanced disease, in combination with even more specific PD-L1 inhibitors, immunotherapy. These are more sophisticated and much more expensive drugs which are used in the metastatic.
Yes. Okay, so we just have just a few minutes and we are going to wrap up. But before we do, Dr. Beatrice, could you tell us about your wonderful medical tourism place that hospital in the heart of the green leafy Ghana, where people can fly in and have, all of their care taken. Could you like to tell them a little bit about that before we move on to hearing other people and to sign off and to say thank you?
Yeah, for those who haven't been to Ghana before, you have my invitation, and I warmly welcome you to Ghana to come and visit Kumasi specifically. It's a nice place, the Green City, and it's in the middle of Ghana. And the Peace and Love Hospital is open for people who want high-class treatment and care. We do not only use medicine, but we also use our warmth and our creative ideas, and we make sure that you feel at home when you come. If you want to come from outside, you can let us know, and we will meet you at the airport, help you through immigration, and make sure that you are comfortable when you are with us.
That is
we believe that. Hello.
Yes, that's a full package, and we'll put up your details, and we want to say thank you, Dr. Figueroa. How can we help you in these studies? Very quickly, thank you so much, Dr. Beatrice. Dr. Figueroa, your chance. We don't have much time, but tell us how we can really participate in some of your studies.
I'm hoping to build more community. I mean, I think we need more cancer researchers and patients being involved in various different studies in diverse communities. I think that's a really key aspect that I'm keen to contribute to. And so I hope patients will be, involved in studies if they get approached and feel comfortable. And I think our clinical colleagues here obviously are doing fantastic work. So I think we need to solve this problem, not only for one population, but many populations.
Okay. Thank you so much. I'm the founder of BAME Health Collaborative, looking at healthcare disparities in the UK. So therefore, we look forward to talking to you. Dr. Rami, we coming to you. We almost finished. We're coming to the end of the show now. So tell us, thank you for your email so that people can find you. Are you in private practice?
No, I don't do private. I just work in NHS. But I'm happy to collaborate with you if you have any more this informative roundtable or talks about it, just to raise the awareness about breast cancer and the treatments. So by all means, let me know.
Okay, and that has been so great, and it's really an honor to have you here. Dr. Samuel, all the way from Trinidad and Tobago, my land of my birth. I just want to say I'm so super proud to be a Trinidad and Tobago child. So just want you to know that. But please tell me a little bit about you. I know that you working closely with Dr. Clifford, and so tell us, if someone wanted to come to Trinidad to get treatment by you, how do they access?
Well, my primary breast practice is through the Cancer Society, where we screen. So I run their breast clinic. I'm working with Clifford in his new building. So I am setting up my private office there.
Okay. Well, we welcome. We're coming to the end of this show. We'd like to thank again all our panelists for being part of this. It has been very much an informational session, expert advice. There is so much. I mean, the show could have gone on for a longer time, but we want to thank again our sponsors, our partners, Video Index, Savvy Media conveners, Tricia, Zanisha George. I don't want to forget that, independent consultant, and Rebecca Osei, general manager of my office in Ghana, who's doing a fantastic job with Henry Badger, and all the who's watching from Leaders Health and Tech, all the doctors and all the nurses and all the professors who are in that. We just want to say thank you. And COVID, be safe. Attend your clinics. Contact your healthcare provider. Take care of yourself. Be informed. Thank you.